Hello and welcome to Mountain Health Today. I'm Ted Owens, your host, and with me is Harry Weis, President and CEO of the Tahoe Forest Health System. Mountain Health Today is a program about all things health that are important to you, and it is funded and supported by the Tahoe Forest Health System. Harry, welcome and thank you for being with us.
Happy to spend a few moments with you today.
Harry, today we're going to talk about critical access hospitals and future challenges, but just to set the table for the folks at home, what is a critical access hospital?
Yeah, very good question. Critical access hospitals first were allowed to be formed in 1997 by federal regulation, but it means that you're a small hospital located generally more than 30 miles from urban areas or in a mountain region, and that you cannot have more than 25 inpatient acute care beds. So it has those specific basic parameters.
And tell me, does it meet all state and federal regulations, or does it have different regulations upon it?
Just because it's small and limited to a few beds up to 25 beds, it's not allowed to escape any state or federal regulation that the larger 300 to 500 bed hospitals or even larger have to meet. We have to meet every single one of those, even though the technology and the staffing resources might be less. And then there are some additional very technical requirements that we might have to meet as to a hospital and as to our physician team that works here.
Does it have an effect on pricing at all?
No, it not really, but from a perspective of federal or state policy, because critical access hospitals are so small, for example, in California, the average inpatient census is about 6 inpatients. The federal government did see the wisdom back in 1997 when this category of hospital was started, that hospitals could be reimbursed at quote unquote Medicare cost for Medicare patients. That guarantee was not available for Medicaid or other insurances, but they did recognize that to preserve critical access hospitals in America, that at least that feature needed to be in place.
And you're required to operate 24/7?
Absolutely. We're available 24/7. We do have to receive all patients regardless of their ability to pay. We do have to have an emergency department as well, just like the larger facilities do that provides 24/7 care.
And tell me a little bit about the In-Kind Village Community Hospital. Is it under the same licensure? Is it a critical access hospital? I know it's in another state. It might be different.
Sure. And again, critical access hospital regulation is a federal regulation. So Tahoe Forest Health System has 2 critical access hospitals and numerous clinics. And as a side note, about 82% of our revenues are non-inpatient, but yes, it is a critical access hospital in Incline Village, and we have a very devoted community there. Prior to its connection to Tahoe Forest Health System in its first 15 years of life, I believe it did close about 3 times, and we're really privileged to be serving that community and keeping sustainable health care available for them.
The license allows for 25 beds. However, you can flex if the need presents itself. Is that true?
You can flex up to 25 beds depending on your specific license. So a hospital that's critical access might only be licensed for 4 or 6 or 20 or 25. And so in Truckee, we're licensed for 25, and in Incline Village, we're licensed for 4 inpatient beds.
How does the Tahoe Forest Health System as a critical access hospital compare to other rural critical access hospitals that you've seen?
It's probably one of the most rare, special, and positive critical access hospitals that I've seen in America, and I've worked coast to coast in America since 1977. It's a larger critical access system than most critical access systems, having just made up of two hospitals, but having, for example, nearly 160 specialty physicians, nurse practitioners, and physician assistants, along with primary care and the various specialties of care that we provide in ancillary services. It's very rare in America.
Okay, and so should not necessarily be judged by the number of beds, but by the services provided, correct?
Absolutely. And again, our health system works really hard to keep our patients well and out of our emergency department and our inpatient units to a degree better than I think any other rural critical access hospital does.
We're going to take a break in just a second, but when we come back, I'd like to pick up right where we left off. For the folks at home, I'm talking to Harry Weis, President and CEO of the Tahoe Forest Health System, and we're talking about Critical Access Hospital, which Tahoe Forest is, and we're going to talk a little bit about the challenges ahead and some of the past challenges. We'll be back in just a moment. Welcome back to Mountain Health Today. I'm Ted Owens. I'm talking with Harry Weis, President and CEO of the Tahoe Forest Health System. We're talking about critical access hospitals, the challenges ahead. But before we get into that, where we left off, Harry, let's talk a little bit about how you're different than other hospitals in general with respect to your inpatient revenue, discharge numbers.
Right. Tahoe Forest being a freestanding, independent, and sustainable health organization, we intentionally price our inpatient hospital services way below the California average. Back in 2015, we were 49% below the inpatient average charge per discharge of all California hospitals, and we're within 1 percentage point of that today. We're still 48% below that statewide average of all California hospitals. And that's in the backdrop of having a case mix index that's higher, meaning the acuity of our patients is higher than the average California hospital as well.
So, Harry, hospital charges are a matter of confusion across the entire country. Share with us a little bit about how Tahoe Forest compares with respect to that. I think I'm talking about the charge master.
Sure. Every hospital in America has more than 10,000 items in their charge master, and because if we were to provide 10,000 episodes of care, we're the only business in America that receives 10,000 different levels of payment, and we're also the only private sector business that has to provide a service regardless of the ability to pay. Only really the court or the prison system is somewhat equal to the intense responsibility that we have. And so what hospitals have found, for example, in California and in many other states, to be able to generate cash receipts equal to total expenses, most hospitals have to have a charge level that's approximately 4 times what their expenses are to generate cash receipts equal to expenses.
So, but to be clear, they don't collect that.
They do not, because there's many patients where they receive no payment or low payments, etc. And so the average California hospital collects about 25 cents on the dollar of every charge that it charges.
And by comparison, did you say where's Tahoe Forest? 1.8?
We're very different here. We've intentionally not tried to charge at the 4 times level. We're only at about 1.8 times level, and that's why we are priced at still 48% below the average inpatient California hospital price, and we're 36% below the average outpatient California hospital price.
And how do you compare, say, regionally? You've got some hospitals to the north, you've got hospitals in Grass Valley, and to the south, and then certainly in Reno. How do you feel that you compare?
We're certainly very comparable to those facilities, and even in the Reno area, which has a much lower cost of living area than the Truckee or the California area. So hospital to hospital, comparing to those types of entities, we are a high value in an expensive healthcare industry.
Harry, how many critical access hospitals are there in the United States?
There's presently 1,350 in the U.S. and 28 in California, and they are a declining number.
And they're a part of how many hospitals are in America? How many hospitals do exist today?
There's almost 6,100 hospitals in America today.
And 1,350 are critical access, and in rural areas, correct?
That's correct.
How many, I understand that closures are a big concern of critical access hospitals. Do you have any information on, or statistics on what's been going on out there nationally?
Absolutely, and we know that all of the residents in our region, it's very important to them that healthcare always exists here in our region of Truckee, the northern Lake Tahoe area, Incline Village, and it's very concerning to us that since 2005, 171 critical access hospitals in America have closed. And to bring that a little bit more close to home, back in 2002, a small hospital in Loyalton, California closed, and all that exists there is a skilled nursing facility. And even to bring it closer to home, Incline Village Community Hospital closed 3 times during its first 15 years of life, but has been sustainable now for the last roughly 25 years that it's been a part of us. But that's not where the stats end. There's some concerning news from the National Rural Hospital Association that we should talk about.
We'll pick that up. We have about a minute left, but we'll pick that up in the next segment. But tell me, how many critical access hospitals do you think are vulnerable across the country? And is Tahoe Forest one of them?
Fortunately, Tahoe Forest is not, but there's 425 high-risk hospitals that are at risk for closure just within the next few years across America.
Thank you. For the folks at home, this has been Mountain Health Today, and we're talking with Harry Weis, President and CEO of the Tahoe Forest Health System, and we're talking about critical access hospitals and the challenges that face them, and we're going to take a look at the future when we come back. We'll be back in just a minute. I'm Ted Owens. You've been watching Mountain Health Today, produced by the Tahoe Forest Health System. And I have with me Harry Weis, President and CEO of the Tahoe Forest Health System. We've been talking about critical access hospitals, of which the Tahoe Forest Hospital is, and some of the threats that face them. Harry, where we left off just a moment ago was that over 400, I think 425 critical access hospitals are at risk. What do we know about healthcare costs and the drivers of that vulnerability?
Right, and there's about 10 states that really cover a lot of these 425 that are at risk, but many, I think at least a third of rural communities in America have declining jobs base, have other economic variables that are declining versus increasing, and certainly growing numbers of uninsured patients, growing numbers of elderly patients, and typically 90% of America's hospitals really struggle financially covering Medicaid and Medicare payer types. So these are some of the variables that are really contributing to an increase in the struggle of rural hospitals in America.
Harry, healthcare costs continue to rise, and I'm talking about the cost to deliver healthcare for a variety of reasons. When we look back on our history, are we on a steady pace, a hockey stick kind of a rise? Where are we?
We're clearly in an acceleration mode. I'm speaking of large regions or the United States on a per year basis. And back in 1987, the federal government decided, I think wrongly so, to abolish the Certificate of Need law, which required an objective view of, are there additional beds needed, additional CT scanners, MRIs, surgical services, heart surgery programs, trauma programs, et cetera, because excess capacity is actually very inflationary to healthcare, and increased competition is very inflationary to healthcare as well. So we've really seen it took 222 years for America to learn how to spend $1 trillion per year on healthcare. But what's especially noteworthy, and that was 1776 to 1998, but 11 years of that is the period of 1987 to 1998, where we really saw a lot of acceleration, a plethora of freestanding healthcare providers popped up, and uncontrolled hospital programs that were redundant popped up as well. So tremendous healthcare acceleration. And then from 2006 to 2012, we saw healthcare costs double again to $2 trillion per year. And then from that period to 2019, we've seen healthcare costs double to $4 trillion a year. And then now we're in that period of between 2019 and 2023, where we're at risk to accelerate further to $5 trillion per year. And these are per the Center for Medicare and Medicaid Services estimates.
So your statement on capacity is counterintuitive to what we learn in college, Econ 101, supply and demand. So it drives, excess capacity actually drives the cost of delivery of healthcare up.
Absolutely. Excess capacity and increased competition are both two large annual inflation drivers to healthcare, and it's vitally important that every resident in America understand this economic rule, because it's driven by the fact we have to provide a service regardless of the ability to pay. And there's 40 million people in America who do not have health insurance, and another 100 million who are underinsured.
Harry, you're critical access hospital. You're in a rural area, but an area that has grown in population. We don't know how much it's grown coming out of the global pandemic period. But tell me about some of the capital improvements that have been made in the Tahoe Forest Health System.
Absolutely. We're pleased, based on greatly improved team financial performance since 2015, that we've been able to invest $75 million in equipment and new patient care space in our health system, which is really vital for us. And we have developed a master plan over the next 10 years that totals roughly $407 million of critical patient care clinic space, patient parking, and equipment to serve all of the various communities we're located in as well.
And tell me a little bit about charity and charity care, bad debt. Have you incurred great numbers there?
Right. We do have very large numbers, over $82 million in charity care mostly, and a little bit of bad debt in just the last 6 years alone. That number has really increased. as we've really changed the focus of our health system, where all of our directly affiliated providers are required to take all patients, whether they're uninsured, Medicaid, Medicare, or other coverage. And so we really believe strongly in timely healthcare access for all patients in our region.
We've only got about 30 seconds, Harry, so I want to get this in. Strong balance sheet.
We do have a very strong balance sheet. It's improved phenomenally from 2015 to 2021, and we're continuing to grow that year by year with the commitment that it's going to be great 10 years out.
Well, perfect. Harry, I'd like to thank you very much for being with us today. Very interesting information for the folks at home. This has been Mountain Health Today, produced by the Tahoe Forest Health System. We've been talking to Harry Weis, President and CEO of the Tahoe Forest Health System. I'm Ted Owens, your host, and I'd like to thank you for tuning in.